Dear friends, in my lecture series in obstetrics and gynecology, there are a few topics which are useful for clinicians in their day-to-day practice. And one of such topic is management of fibroids in pregnancy. The fibroids are the most common pelvic tumors in pregnancy as they are seen in reproductive age group. The prevalence is 10.7% in the first trimester, and as we all know, they are more common in South Asians, Africans, and Middle Eastern people. They are associated with advancing maternal age. They are considered to be innocent, and previously it was thought that they have no effect on pregnancy, but some adverse effects on pregnancy have been noted, and the most challenging of which is postpartum hemorrhage. It could be so severe that the women may end up in a peripartum hysterectomy. As you all know, the different types of fibroids, subserous, submucous, and intramural, well, its effect on pregnancy depends on its exact location. A sessile pedunculated fibroid or an intercavitary fibroid, which is far away, may have no effect, but a big fibroid on the lower segment may tremendously affect the growth of the fetus. So let us now see what effects do these fibroids have on pregnancy and what is the effect of pregnancy on these fibroids. So the effect of pregnancy on fibroids, there was a traditional teaching that fibroids increase in size during pregnancy. This is thought of because we know estrogens are present in excess levels in pregnancy, and fibroids are dependent on their growth for estrogens. So, estrogen is thought to be the factor responsible for their growth. However, ultrasound surveillance suggests that pregnancy has various effects. If you look at various studies, in a study on 72 women, fibroids remain virtually the same in size as they were before pregnancy. In another study on 107 women, fibroids rather decreased in size during the antenatal period. However, it has also been seen that the potential increase in size of fibroids is more likely in the first trimester than in the third trimester. Those located close to the cervix may migrate upwards with advancing pregnancy because of development of lower segment. Now, the effect of fibroids on pregnancy. 10 to 30% of women may develop a pregnancy complication, and this is more likely when the fibroid volume is more than 200 centimeter cube compared to a fibroid volume less than 100 centimeter cube, in which less complications are likely to occur. If you look at the effect, there could be pain, which is the most commonest complication, and this pain is seen with fibroids more than 5 centimeter in diameter, and it is more common in the second and third trimesters. Red degeneration of fibroid or torsion of a pedunculated fibroid could be the cause for this pain, and which is mainly due to prostaglandins which are released as a result of cell damage. Now, fibroids can also cause pressure symptoms, especially if they are located anteriorly on the bladder and if they are located posteriorly on the rectum. If you see this picture by Munroker in 1908, this clearly depicts that fibroids were known at that time, and this shows obstructed labor caused by a lower segment fibroid. So let us see what the various complications are. They could be maternal or fetal. Maternal, failure to progress, placental abruption, placenta previa, choreo or endometritis, more tendency towards a cesarean section, and then PPH because the uterus does not contract well when a fibroid is present, and this leads to atonic postpartum hemorrhage, and even retained placenta. The fetal complications are preterm labor, preterm premature rupture of membranes, leading to a preterm neonate, fetal growth restriction, and because the fibroid occupies the volume of the lower segment, then it may cause malpresentation. Now let us look at the management. Well, when we think of management, all treatments we know should be evidence-based and should follow certain protocols. But for cases of fibroids with pregnancy, there are no such meta-analysis, and meta-analysis of randomized controlled trial forms the level 1 evidence. So such evidences are not available, and the reason for this is some limitations. There are several factors which make it difficult to assess the impact of fibroids on pregnancy and its outcome, and it is difficult to identify specific fibroid characteristics. Therefore, interpretation of evidence is limited because there is heterogeneity of study populations. So no two women who are having fibroids have the same characteristics. There is also a difference in the method of ascertainment. Some studies are prospective, while others could be retrospective. The gestational age at diagnosis and fibroid characteristics vary. Also, there are small number of adverse events. Ascertainment bias in selecting study participant is always there. There is inadequate adjustment of confounders, and some small fibroids, which are less than 4 to 5 centimeters, may not be detected in pregnancy because of flattening out with the growing uterus. So mechanisms whereby fibroids may cause adverse obstetric outcomes are not clearly understood, and this is the reason why we have limited evidence. Now let us look at the antenatal management. So if a woman has a fibroid, with pregnancy, she is considered to have a high-risk pregnancy, especially if the diameter of fibroid is greater than 5 centimeters and it is located near the placental site or near the cervix. In such women, we must discuss the implications this fibroid may have on pregnancy and ensure timely management. Treatment and prevention of anemia is mandatory because symphysiofungal height in such cases is inaccurate. Serial growth scans are advised in order to assess fetal growth. And a regular ultrasound surveillance helps in identifying a rapidly enlarging fibroid. It helps in identifying those fibroids which are suspicious of malignancy. It also helps in detecting malpresentation, especially in the later stages of pregnancy. Now, in some cases, fibroids are difficult to define on an ultrasound, and even there may be abnormal characteristics, but it is difficult to define whether they are malignant. In those cases, it is important to go for an MRI for diagnosis. Whenever a woman has pain and she's having a fibroid, we consider two differential diagnoses. One is red degeneration and the second is torsion of a pedunculated fibroid. For this, ultrasound is essential. Then it is also essential to check the viability of the fetus and in cases of pain, again, to rule out preterm labor. Well, when a woman comes with pain and she has a fibroid and is pregnant, the first thing which comes to her mind or the first differential diagnosis is red degeneration. So this is a condition which is known in fibroid, which is known in women who have fibroids and when they present with acute pain. We need to go for an ultrasound. In an ultrasound, a typical heterogeneous echogenic pattern or a cystic change in fibroid does suggest cystic red degeneration, but this condition is non-specific. It is not diagnostic of red degeneration. Such women may require hospital admission for symptomatic treatment. They require supportive care and use of a hierarchy of analgesics. Paracetamol and opiate-based analgesia is safe in pregnancy, but ibuprofen is the most effective analgesic. So use of NSAIDs like ibuprofen and indomethacin given every 4 hourly up to 48 hours may help in relieving this pain. But the caution with NSAIDs is that they should not be given in the third trimester because of chances of inducing premature closure of the ductus arteriosus, neonatal pulmonary hypertension may be caused, chances of oligohydramnios, and fetal or neonatal platelet dysfunction. So they can be used but should be used for a short period and with caution. In those women who do not respond to analgesics, surgical intervention has been described. Now, whenever there are fibroids which are located lower down, there could be a malpresentation. And the commonest malpresentation is breech. In all cases of breech, we do think of external cephalic version. So uterine fibroids as such are not a contraindication to external cephalic version, and they may be considered in women with malpresentation on individual basis. However, there are no studies which have evaluated the success rates of external cephalic version in women with fibroids. Now, whenever you think of a fibroid, you always think of myomectomy as well. Myomectomy during the antenatal period or during a cesarean section, the indications are specific. An antenatal myomectomy can be done if there is severe pain from a degenerating fibroid, if there is a large, rapidly enlarging fibroid, which is causing problems, if there's a fibroid greater than 5 centimeter in diameter, especially in the lower uterine segment, if a pedunculated fibroid has undergone torsion, or there's a potential for harm like hemorrhage, uterine rupture, miscarriage, or preterm delivery. It is avoided especially if an intramyometrial incision is required. Now, this, if it is to be done, can be safely done in the second trimester. And in all such cases, consideration must be given to transfer of a woman to a center which has expertise in performing such procedures. There could be a fibroid which is seen easily prolapsing into the vagina. So a pedunculated fibroid lying in the vagina. Elective removal of these prolapsed fibroids in pregnancy is not routinely advisable. The risks are likely to outweigh the benefits. Unless it is easily accessible, it is pedunculated or has a thin stalk which could be easily cut, should not be tried. However, there are specific indications like a clinical significant bleeding, excessive pain, presenting with urinary retention, and rarely infected fibroid in pregnancy, which is prolapsing out, could be removed. We should also consider the risks which may occur. There could be excessive bleeding, hemorrhage, rupture of membranes, and it could lead to pregnancy loss. So, whether to remove or not, this need should be assessed on case to case basis. Now, if the fibroid is seen prolapsing out of the cervix, a transvaginal myomectomy is the procedure of choice, but it also depends whether the origin of the pedicle is from the cervix or whether it is coming from somewhere inside, and also on the thickness of the stalk or the base. Well, before doing such a procedure, an ultrasound scan should be done in order to exactly locate the fibroid, because an asymptomatic lower segment fibroid may sometimes become submucosal and prolapsed, and it may become, which is submucosal, an asymptomatic fibroid, which is submucosal, may become intrauterine with advancing gestation. Now let us look at the intrapartum care. Such women are always advised to deliver in high-risk units which have all the facilities for blood transfusion, for emergency cesarean section, and even for cell salvage, especially in those women who do not prefer blood transfusions. A vaginal delivery may be attempted, and for which it is crucial to ensure that the fetus is cephalic. The relative contraindications to vaginal delivery include cervical fibroids, fibroids which are on to the lower segment of cervix and which can obstruct labor, or those which can cause fetal malpresentation. Elective cesarean section is advised when there is a previous history of myomectomy, and during that procedure the endometrial cavity was breached and or the defect was large, or the mucosa was entered into at the time of myomectomy. All women who had a laparoscopic myomectomy performed for an intramural or submucosal fibroid should essentially have an elective cesarean section. Now, during labor, intrapartum care, if there is a previous myomectomy and the woman is suitable for vaginal delivery, then continuous fetal heart rate monitoring to detect early signs of rupture is essential, and intravenous access should be secured to aid timely response. And some people suggest extending the use of oxytocin infusions from 12 hours to 24 hours following delivery to reduce the risk of PPH. So all care should be taken to prevent PPH at this stage. If not contraindicated, ergometrin, which is a potent uterotonic and which has a very good effect in a uterus with fibroid because it has a long duration of action, so it should be used. Once PPH has occurred, then management includes concomitant use of oxytocin and a balloon tamponade. You may do a uterine packing if there's a large submucosal fibroid which is interfering with the placement of a balloon. In cases of torrential bleeding, major obstetric hemorrhage protocol is to be adhered to. Having an intravenous access, giving blood transfusions, giving uterotonics according to the protocol should be followed. Facilities for cell salvage and intervention radiology, if available, can be used. Uterine compression sutures, internal iliac artery ligation, and the use of a uterine tourniquet, bilateral uterine artery ligation, can also be the surgical procedures which need to be tried. In some cases, there could be torrential hemorrhage not responding to all of these, and then the woman may need a peripartum hysterectomy. Now, special precautions need to be taken at the time of cesarean section. The consent. Large or cervical fibroids, the consent must include a knowledge of the procedure, a knowledge that hysterectomy may be required, and that the woman may require admission to an intensive care unit and modified skin incision. That means instead of panel-steel incision, we may do a vertical incision as well. Abdominal incision used may be vertical midline, especially in those women who have cervical fibroids, those which require a classical uterine incision in order to avoid cutting the fibroid which is present on the lower segment, or in women who had previous surgeries and significant pelvic adhesions are anticipated. The uterine incision should be made away from any fibroid. To reduce the risk of torrential hemorrhage, a distance of 2 centimeters is considered and is safe. Fibroids can interfere with the feasibility of cesarean section, especially cervical fibroids, in which a vertical incision may have to be given on the uterus. For gaining access in the lower segment, often classical cesarean section is resorted to. The length of classical uterine incision should be at least 10 centimeters. Broad ligament fibroids can result in dextrorotation. So, after opening the abdomen, you must identify the round ligaments of both sides. If one side is not visible, then you may have to Unrotate the uterus before applying the incision. Identifying key anatomical landmarks, that is round ligaments and tubes, is essential. Dextral rotation should be corrected. Cell salvage should also be utilized where possible. Pelvic adhesions anticipated if there is a previous myomectomy. A subumbilical midline incision, if it was there previously, significant adhesions should be suspected. Care must always be taken to avoid injury to the bladder. Again, every effort should be made to avoid cutting of the fibroids, as it can be impossible to close the scrotum side with fibroids adjacent to it. Intraoperatively, a sterile probe cover can be placed on an ultrasound transducer and sterile gel applied to the uterine serosa, and then identify and locate the fibroid, and after which the best incision site can be located and marked. Uterine artery ligation can be taken immediately following a cesarean section, and this has been prospectively evaluated. It prevents PPH, prevents excessive bleeding in many cases. This procedure decreased blood loss and reduced the risk of myomectomy or hysterectomy. In those requiring peripartum hysterectomy in presence of broad ligamentary fibroids, it is advisable to deal with the site that is anatomically normal and accessible first. Every effort should be made to identify ureters in such difficult procedures. Now, the question arises whether we should do a myomectomy at the time of cesarean section or not. Growing evidence suggests that myomectomy undertaken at the time of cesarean section is safe and cost effective because it avoids possible fibroid removal which may be required at a later stage. So at that time, if the fibroid can be removed, it prevents an unnecessary second surgery. So some of the possible indications of myomectomy could be fibroids causing difficulty with the closure of uterine incision, so they're coming in way of closure. To facilitate safe delivery of the fetus, especially if the fibroid is located on the lower segment. Large fibroids greater than 6 centimeters in diameter and visible subserosal fibroids. So these are clear-cut indications in which a myomectomy can be done. Now let us look at what evidence tells us. In a retrospective case control study, 47 myomectomy were done at the time of cesarean section, and in 94 cesarean section, fibroids were there, but myomectomy was not done. It was seen that there was no significant difference in the hemoglobin levels, the incidence of blood transfusions, and the chances of postoperative fever. However, there were significant differences in the mean operating time with myomectomy. So removing of a fibroid in addition to a cesarean section requires additional 15 minutes. The length of hospital stay also increased, that is additional 0.4 days. The most common site for myomectomy as within the uterine incision rather than those that were large intramural and found adjacent to the fallopian tubes. The findings of this study are supported by a 10-year study in China on 1,242 women. Again, a study in 2014 on 16 women, which had similar conclusions in patients with fibroids greater than 5 centimeters, and another study on 76 women with fibroids, in which they found cesarean myomectomy to be feasible, especially in women with subserosal fibroids and fibroids located in the body of the uterus. So all these studies tell us that myomectomy can be done at the time of cesarean section in specific conditions. However, the matter of concern is incomplete removal of fibroids at the time of cesarean myomectomy compared to myomectomy in a non-pregnant state. So if there is incomplete removal, there's again a risk for further treatment in future. If clinically indicated, national guidelines from Canada now support both antenatal myomectomy and cesarean myomectomy. In another study on 51 women for safety of cesarean section, cesarean hysterectomy for fibroids, the risk of bleeding, the drop in hemoglobin levels, the postoperative fever length of operation, and length of stay were comparable with cesarean myomectomy. So evidence does tell us that myomectomy can be done. Now, postnatal care. Fibroids regress from early pregnancy to 3 to 6. They take 3 to 6 months postpartum in over 70% of them. While the precise mechanism for fibroid regression remains unclear, mechanical and cellular changes at birth and involution of the uterus and a hypoxic mechanism has been labeled to be the reason for shrinkage of fibroids postpartum. Complications of fibroids in the postpartum period are, however, rare, but still have been described. One such condition is pyomyoma. Just like we have red degeneration of fibroid, this is infective condition in which there's infarction and infection of fibroid, and this is life-threatening. The signs and symptoms include abdominal pain, fever, and septicemia with common organisms such as Clostridium. Again, imaging findings are non-specific. The definite diagnosis and treatment can be achieved by laparotomy with either myomectomy or at times hysterectomy. Computed tomography, CT scan, guided drainage of pyoma has also been attempted and is possible in specific situations. Rupture of degenerated fibroids in the postpartum period can also happen. In these cases, women present with acute pain and ultrasound reveals a large hyperechoic mass on the uterine wall and free fluid in the pelvis. Again, exploratory laparotomy is required to confirm the diagnosis and to treat the condition. Now, evidence as to what can happen in future pregnancies. Studies on outcome of pregnancies following a previous cesarean section are less. Spontaneous pregnancy rate as high as 79.3% for women with myomectomy versus 38.6 and 55.9 in interval myomectomy. So the pregnancy rates are a bit low. A study of 29 women, the mean inter-pregnancy interval was found to be 31.2 months. 20% required fertility treatment. This also highlighted that high risk of placenta previa, abnormal lie, and talipes in subsequent pregnancies. So it is important to evaluate in such conditions risks versus benefits. So to conclude, uterine fibroids affect many aspects of pregnancy. They are a significant cause of PPH and can pose challenging surgical problems. Caesarean myomectomy is considered to be a safe procedure. Antepartum myomectomy reduces the risk of peripartum hysterectomy, but may increase the risk of cesarean section. Further studies in similar populations are required for us to have any available evidence. There is a need for greater evaluation on the effect on subsequent pregnancies that follow cesarean myomectomy. So difficulties mastered are opportunities born. So whenever you encounter such a woman with fibroid and pregnancy and who requires a cesarean section and a cesarean myomectomy, you may succeed in removing the fibroid. Thank you for a patient hearing. If you have any questions, please do write to me and please do subscribe to my channel. Thank you.